So yeah, my name is Christina Yadav. I'm one of the flocks here at Sick Kids. There's actually two of us. My counterpart is Cindy Trong, and we cover the Monday to Friday here. Seeing all the ostomy patients, both inpatient and outpatient. Really looking forward to connecting with you all. If you're comfortable to put where you're from, if you could put that in the chat, that will just like help us understand um, maybe how we can connect further. And then feel free to put any questions in the chat. And Stephanie will try and address them as we move along. And if we need to pause to answer anything, we can definitely do that. All right. So I'm just going to stop my video for a sec just so I can continue. All right. So, all right. So this is being recorded, as Stephanie said. Some of the objectives that we are going to cover today. We're going to look over the indications for stoma creation, discuss different types of stomas that you might see in pediatrics, stoma assessment, peristomal complications that can be common in children. What are the principles of pouching? Review some ostomy care and provide you with some resources. Outline pediatric ostomy supplies, how they may differ from adults. Discuss some financial supports that are available for family and caregivers, and talk about when to seek medical attention or when you can loop back with us if you notice any issues with your patients once they leave our hospital. So is there really a difference between pediatric and adult stoma care? I mean, to be honest, the principles of ostomy care are exactly the same, but a lot of the times we do have to change maybe the products that we're using. We have tinier babies that we may not necessarily fit some of the products. So we do have to take these types of issues into consideration. So specifically body size and location, looking at their skin fragility, developmental social milestones, and psychosocial support of the family and the patient. So what do we mean by body size and location? Well, in a lot of our patients, and we'll talk about some of the indications for why they may be created, but we don't always know that it's going to be planned. So we don't always have a choice in where we put these stomas on our patients. And so we have to think about other issues, other structures that may get in the way and may make it difficult for us to put a pouch on our patient and may lead to more complications. In terms of the peristomal skin fragility, I guess you can kind of look at it similar to older adults and seniors. We look at things like reducing skin injury with removal of the adhesives. We're putting products on the patients. What are the considerations that we have to think about in reducing that skin injury? How can we think about the products that we're using and ensure that they're not toxic for the patient? So, for example, some of our premature infants, a lot of these things are not tested on these age groups. So we do have to be mindful about what we're putting on the skin and whether it'll be toxic and absorbed in a specific way that could be harmful to them. They have an immature epidermal barrier, so we have to think about things like chemical friction, skin stripping, friction injury as well. In terms of developmental and social milestones, I mean, we are dealing with different age groups. Here we go anywhere from 0 to 18. So, we've got a few stages that we have to consider how a stoma may affect their quality of life, how it may impact their relationships, or specific developmental milestones that they may want to achieve. A lot of the concerns that we get from families in regards to developmental care for infants is, can I even hold my baby? Can they do tummy time? Can I put them up in a chair? What about the car seat? So these are general questions that we get that we have to target with families, and we try and support them in knowing that there's very few restrictions on activities with a stoma in infants and children. We just have to be mindful about things like putting them on their tummy, putting them prone, and then having the pouch emptied prior to that to prevent disruption of the seal. Things like gas in the pouch and how it may affect potentially coming off. So just understanding how we can incorporate those ideas into their routine cares so that it can support those milestones and those developmental care. In terms of children, We think about their sort of social milestones. Children are very social. They like to show other children what's going on with their body. So we're thinking about things like play therapy and getting them to accept their stoma, understanding what they understand, getting them to understand why they may need it, and understanding how they interpret why they may need it. Using language, of course, that's very important in helping them understand that. So you used to poop out of your bum, but now you poop out of your belly, and this is what is normal for you. And then they often decide who they want to share this with, who they want to show. So we can't necessarily control that, but just knowing them that it's normal and part of their body, and understanding that they'll accept it in the way that they want to. In terms of teens, I mean, there's a lot out there. We think about like the developmental and social milestones that they may go through, relationship building, sexuality, acceptance, and just like body image. These are the things the conversations that we try and support, and trying to use things like social media, finding the right supports out there. There's a lot of information on the internet that can um, sometimes not necessarily give them the greatest picture. So we just want to direct them in the right ways, that gives them sort of a positive outlook and outcome on how this can support their quality of life. When we look at the psychosocial support, we're not just supporting the patient, we're supporting the family, because oftentimes they're both learning to cope with the stoma care. So what is their understanding? What is their acceptance of it? And sometimes, they don't necessarily have a choice, right? They had their child was born. They didn't know that they were going to require surgery, and now they're having to deal with both a newborn and as well as a stoma. So it's a lot to process. So just taking that into stages, um, understanding how it may be also a part of grieving that they may have in regards to the normalcy of their child, and how to sort of accommodate with those feelings that they may be having. In terms of indications for stoma creation, I tried to break it down, and sort of the most common things that we may see. Most of the time, there is some sort of obstruction, congenital malformation. We may see patients with inflammatory bowel disease, trauma, and dysmotility. So for obstruction, we see things like tumors, strictures, atresias in the bowel, that may impact the flow of the stool, and that may require resection. Same thing with congenital malformations. A lot of the pediatric diagnoses that we see are anorectal malformations, Hirschsprung disease, and perforated anus, cloacal anomalies. Again, these are things that you may not necessarily see until the patient is born. Um, and they're often found once we don't necessarily have that first pass of meconium. Or we do an inspection of the patient and then we see that they don't have an anal opening. So it is a surprise to some families. It's a lot to digest. But typically, these things are, I would say, shorter term, not forever. So there are different stages that they have to go through for their surgery based on the type of disease that we're treating. And I would say that usually they have them for about anywhere from 6 months to about a year and a half. In terms of inflammatory bowel disease, we see a lot of Crohn's and ulcerative colitis. We're hoping that in these patients, when we create these stomas, that we're going to give them a better quality of life, reduce the bloody stools and trips to the bathroom, allow them to eat the foods that they would want to eat, that they were used to love to eat, allow them to gain weight, and have more energy. In terms of trauma infection, we don't always, again, have a plan necessarily for this. They can be a surprise, for things like spinal cord injury, bowel perforations, diverticulitis. One of the ones that we see in our neonates is necrotizing enterocolitis. They're trying to feed, they have bloody stools, and then we need to sort of make this diversion to allow them to feed and grow. In terms of dysmotility and continence, a lot of the indications would be for neurogenic bowel and bladder, chronic constipation. A lot of our patients that decide that they want to have a stoma created are just wanting to increase their independence, the predictability of being able to change an appliance instead of having to soil in a brief. or perhaps they had what was called a mace, where they were trying to do irrigations to clean out their colon. But it just is time consuming and they don't want to sit on a toilet to have to do those irrigations. So for them, it is a sense of independence, as promoting more of a routine, getting them into that predictability. I like these pictures that are provided by Contact. They help to sort of visualize the types of stomas that may be created and where they may be. This may be a review for some of you, but it just helps to visualize sort of what's coming out of the patient and where is it, or how many pieces are also coming out onto the abdomen. Very important to know. When we look at the surgical notes or we pass on to you in the community, we try and distinguish things like what is the proximal and distal end. Um, so the three types of stomas that we generally see are the end stomas. So there's one piece of the bowel created on the abdomen. The proximal end is the one that is functioning, is sutured out onto the outside of the abdomen, whereas the distal end is usually sewn over internally. We often call that a Hartmann's pouch. And then there are also double barrel stomas, where the bowel is divided, both ends are sutured to the outside of the abdomen. There's a proximal stoma, meaning the functioning end, which the stool comes out of. The distal end is known as a mucus fistula. They can be together, they can be separated, often a challenge when they are very close proximity, but not quite close enough to go under the same device. We'll show some photos of what that may look like. And then we also see our loop stomas. Our loop stomas is one continuous bowel brought out through the abdomen, two cut openings, eight side by side. We use a rod usually to hold it above the abdomen and prevent it from retracting, usually kept in for 7 to 10 days. After surgery, there may be some continuity in bowel, so you may see some mucus and discharge rectally. And we always tell our families that despite the indication for creation, if they have an anus and they are still able to expel through the rectum, that they may see rectal discharge, and it is normal. And if there was infection or contents left over distal to the stoma, that may take some time to expel from the body. So not to be alarmed if they still have stools distally. Sometimes they may need an irrigation to clean that out, but if this was a concern of your clients ongoing, please let us know, and then we can sometimes help them get those irrigations started. Here are some real life pictures of those types of stomas that we discussed. So this is a perfectly created end stoma, nice and round. The opening is right in the center. Here are examples of double barrel stomas. We usually have to look at the notes to understand which is the proximal and distal stoma, because sometimes unless you sit there and you watch it, you won't necessarily know where the stool is coming out of. You can see that this one on the left here at the double barrel is very nicely situated, so we can likely get it under the same pouch, whereas the one that's on the right is a little bit separated. So we have to think about how we're going to protect the skin in between those stomas. And then here's a loop, sometimes difficult to see the two openings, but you can see again that it's side by side, and then just understanding sort of lateral and medial, which one is the proximal and distal stoma, can help us understand how to pouch it the best. So intended stoma assessment, these are the things that we're looking for when we're assessing our stoma. Then we try to highlight some of the pediatric considerations that might be different or might be more common in our children. So the color should be nice and beefy red and pink. Of course, we don't want anything that's going to look have circulatory compromise, such as a dark black, purple, blue, or pale stoma. Having said that, if it's a newly created stoma, it may be a little bit irritated and gone over a lot of trauma, depending on the type, the indication for creation. So it may not necessarily be nice and red in the beginning. We typically monitor that for the first 4 to 6 weeks. And so if you continue to see something sort of after a few weeks of creation and it's not looking this nice normal color, to notify us. The mucosa should be moist and shiny, not flaccid and dry. In kids, they can be quite friable and bleed easily, especially depending on the amount of injury to that bowel. Sometimes they just bring it up emergently, and it's not necessarily the healthiest bowel, but it's what they could bring up at the time. The shape and the size can vary in the first 6 to 8 weeks post-op, so we're always remeasuring and reassessing the size of the stoma to ensure that we have the proper pouch. Typically, we want it to be sort of round or oval. They can be irregular in shape, which can cause some difficulty sometimes with finding the right pouch. What we don't want to see is retraction, which is like at or below the skin level, or prolapse, which can sometimes affect the pouching and the wear time of the pouch and lead to leakage. For children, they will require reassessment every couple of months. They're growing with their stoma. Their stoma doesn't necessarily get bigger, but they just sort of grow with it. And they get more active, which might require a different type of appliance. For protrusion, the ideal is about 1 to 2 centimeters above skin level. Don't always achieve that in kids. And what we do often see is sort of prolapse or hernias around the stoma is very common due to their immature musculature. Again, we need to accommodate with our supplies to help reduce the risk of leakage with those things. Effluent will depend on the type of stoma that's created. So an ileostomy would typically be liquid porridge consistency, whereas a colostomy would be more soft form, sort of toothpaste consistency. These are the things that we're telling our parents when they're looking out for what to look for in the pouch. We don't want anything that's like consistently diarrhea or very, very liquid, very foul smelling, or little to no stool output. Having said that, when we look at effluent, we do think about things about diet and how that may affect sort of the smell, the contents, and the consistency. Um, in terms of effluent, we don't want to see bleeding in the ostomy pouch. For babies, it can be a sign of recurrent neck. We do think about things that if there is bleeding or change in the stoma output, were there things that we may have done to it? Could they accidentally have caused trauma to the stoma that might have changed it, the output or caused bleeding? So we just have to be mindful about activities and how they can affect that output. In terms of the peristomal skin, we hope it's going to be free of any redness or irritation around the stoma, but we often do see, sometimes ulcerations, yeast, pinpoint rash, or mucocutaneous separation, which I'll show an example of. And prolapse can be common in children, again, just because of the immature musculature. It's not necessarily a medical concern. We do want to document the length of the bowel, but we do want to notify our teams if there's any narrowing of the bowel, any discoloration, any change in bowel function. Some things that we do tell our families to do is put a cool cloth over the stoma to help reduce the swelling in the stomas, or even sugar. White granulated sugar on top of stoma can help shrink, sort of like osmosis, and what was I going to say? Pull in the water from inside the stoma to help reduce it. If they feel that it's persistent and affecting, obviously, the coloration, their digestion, their distension of the abdomen, and they're irritable, then we would say come to emergency to get that assessed. When we talk about the os, we're talking about sort of the aperture, where is the stool coming out of. Ideally, it would be nice if everything was in the center, but often they're tilted to one direction. That can cause leakage. I'll also show some photos of that and talk about ways that we can help reduce that. So peristoma complications can happen for many different reasons. So leakage and poor adherence can be due to sometimes they don't have a regular change schedule. We're leaving it on too long, which is causing issues with our skin. Poor location, we don't always have a choice over this, but sometimes it's just near a bony prominence, such as the hip bone or an umbilicus, that is impeding sort of the flat ability of that flange to stay on the skin. Poor construction, again, don't always have control over that. Sometimes we do the best we can do and we're surgically creating these things. Aperture being off center, it may start out in the middle and then sort of move off to the side. So we just have to tailor our products to help reduce leakage from that. Skin sensitivities, children can be allergic to a lot of different things. What are we putting on the skin that might cause irritation, or what are we using to remove these products to also reduce irritation? If they have previous scars or incisions, often more than not, we have to think about these things and how they impact, again, the adhesion of our appliances. So these are examples of some of our patients that we've seen and why, how close things are and why sometimes we have difficulties. For example, this baby, when he was created, he had a neck. And so they did a double barrel stoma, but you can see that they're separated on different ends of the abdomen. The right being the proximal stoma and the left being the mucus fistula. The mucus fistula, it just sort of closed off, which is not necessarily a medical emergency. It's there as a placeholder. It's still there internally, but it sort of disappeared in time. The body's going to do what it needs to do, but it's not affecting, obviously, the ability to expel the stool. When you look at the picture to the right, that incision that was closed, this is an prem about 25 weeks. We had issues, obviously, with keeping that incision closed. So it did dehisce and it caused some irritation and wound dehiscence, some drainage. But what you can see on the right there is there's some excoriation in the wound related to actually leakage from the stoma. Where I've put my arrow, there is actually a fistula on the skin. So this had caused leakage, constant leakage, multiple bag changes a day. So we really had to learn how to isolate the stoma from the wound to help it obviously reduce the bacteria in the wound and help the wound heal, and then minimize the skin injury that you can see on the skin. There's some skin stripping on the right there, sort of the superficial ulceration that came from having to change the bag so often. So for this patient, we just had to move to a much smaller ostomy appliance, kind of similar to a neonatal urostomy pouch. We weren't as concerned necessarily about emptying the pouch because the output was not as much, but we just really needed something a lot smaller to isolate the stoma from the wound. These are some other issues that can happen. So our babies, they can be a little bit pudgy in some areas, and then they've got these nice skin folds. We've got incisions that don't necessarily heal very well. They have keloids, and so it causes the abdomen to be uneven in surface. You can see the belly button is also very close on that retracted stoma. Again, where the arrow is, that's where the stool is coming out of, not what you would think in those that nice like brown mucus fistula on the left there. That's not actually where it's coming from. We can see that there's some skin excoriation where the stool is draining and kind of pooling. For this patient, we used a different type of skin barrier ring and really try not to block where that stool is coming out of. And then try to fill in these sort of divots and folds, make the umbilicus flat to allow for the pouch to adhere better. When we talk about mucocutaneous separation, this is an example here you can see on the right photo. This is a loop stoma, but there is a little separation from the skin and the stoma where the sutures were. We use stoma powder and Cavalon to fill this in, or a barrier spray to fill in the area, to act as sort of like a Band-Aid, a bandage over it to protect it from a effluent getting into it, and then put our barrier ring on top. These are examples of prolapse that we can see. So the one on the left, definitely we would be concerned and want to notify our team members of if we knew that it was sort of firm, this large girth, and it was sort of affecting the output because it's dilated in some areas and sort of more strictured in others. So this patient had to get a revision because it was impact, no pouch could really stay on. We were worried about constriction of the actual device on the stoma because it sort of fluctuated in size. And then on the right, we sort of see a milder prolapse, but again, we see a lot of excoriation because we're having difficulties with pouch adherence. Similar to adults, these are the complications that we often see with appliances that we put on our body. So things like contact dermatitis, usually an allergic related complication, sometimes a reaction to adhesives on the flange or the tapes. They can appear as these small red bumps that may affect areas in contact with the appliance. Sometimes it sort of mimics the actual flange that you put on the skin. So we often think about um, perhaps changing the appliance to a different adhesive backing, a different brand, perhaps applying topical corticosteroids, maybe putting a skin barrier in between there. And then our typical is usually stoma powder and barrier spray as a first line of defense. In terms of excoriation, it can be leakage and irritation from the skin, the effluent being on the skin. It's often red, it can be bleeding, so it can be painful. Children can itch at it because it's moist. Could be an ulceration in skin that can have some depth and drainage. So we may require just a change in appliance, perhaps maybe from a 1 to a 2 piece that can provide better adhesion. We may think about things like barrier protection, such as a ring, or changing to a convex device that sort of has protrusion in the flange that can help to push up the stoma, get the effluent more into the device than sitting on the skin. Also use stoma powder and barrier spray. It's literally all over our hospital because it's probably our first line of defense for a lot of things because it's the easiest thing that we can do to help heal the skin. And then we have yeast infection, which can look more like a bumpy red raised rash that can be quite itchy, sometimes requiring a topical antifungal. We typically increase the frequency of the applying changes for any of these issues until the skin improves. May think about a skin barrier, and then we have something called a silver powder that we use that can work as an antifungal or an antimicrobial on those areas to help reduce itchiness and to help inflammation. So we're looking at principles in pouching, very similar to adults, but maybe some considerations that we have to think about for our children. We're really trying to find something that's going to establish a routine, something that they can do empty with diaper changes or have predictability in being able to change it. So we try and establish a routine, let's say with bath time, that on the bath days that we change the appliance. That is something that's easily incorporated into their regular routine. We want to promote comfort with our products. Again, some of them are not necessarily, we're using adult products sometimes on children's skin. We want to ensure that they're comfortable, that they're not causing pressure injuries, that we're not necessarily stripping the skin with these adhesives. We're trying to find the most appropriate size, but again, sometimes we have to go to adult products to put onto their skin. So we may need to tailor it by cutting down the product and making it a bit smaller. What is the ease of emptying? Is it easy for the parents to empty it, for example, into the diaper? Is it easy for the patient to empty it into the toilet? Would they maybe prefer a different type of method for emptying it, such as a syringe, versus just putting it into a basin or the diaper or the toilet? And then how can we manage the output? Are we sure that the pouch that we're putting on is able to control the amount of effluent coming out? If it's very liquid, do we need something that needs to go to straight chain, perhaps overnight, to prevent leakage of the appliance and filling up of the bag? And then, of course, we want to protect the skin. So we just have to think about the types of products that we're putting on the skin and think about how they may interact with the skin. You know, if a child is quite sweaty, if it's the summer, if it's the winter, their skin can change, can be drier, can be more moist. So how do we have to tailor our what we're using to help accommodate for these changes? When we look at factors affecting pouching, again, it's very similar to the slide in the beginning. So age, body shape, location, the type of ostomy and the type of drainage is going to affect us. The characteristics of the stoma, they may evolve over time. That may affect the skin because of leakage. Activity level of the child. Do we need to add any extra products that will help keep this on the child? So a belt, a pouch, an extra pouch on top. And then we had to think about the cost of supplies. I mean, these can be quite expensive. We'll go over just an example in case this is new to some of you, but really the cost for families can be quite high. If we're looking at having this for a year, it could be anywhere from $1,000 to $1,500 or more, depending on um, the type of stoma or if they're having issues. When we're looking at dexterity and visual acuity, for us, we're not always just looking at the patient, but we're looking at the parent. Do they have any limitations in perhaps their ability to cut out an appliance? Are they able to see what they're doing? So we do have to take these into consideration, help them tailor, find a plan of how best to be able to use the products and put them on appropriately. So general care considerations for children, we don't want the pouch to get too full. We try and empty it when it's a third to half full to prevent it from pulling off. If there's any gas in the bag, we try and burp it to help the gas come off because they can pop off quite fast. We want to empty the bag before it fills to help prevent it leaking. And odor drops. This is as a common concern from our families is just the smell. What are they going to do, if the other children can smell it at school or in the bathrooms at school. So there are odor drops and sachets that can help to thicken the stool if it's too loose and sort of help with the odor as well. Changing the pouch. So this is not necessarily a science. Like we can't really say exactly keep it up to a week, but pouches can remain on for up to a week as long as the skin is in good condition and there's no leakage. Of course, if there's any issues with redness, rash, or irritation, then change it more frequently until the skin improves. Often for babies, a day is good, but if you can get a day to 3 days, that's even better. Toddlers, 2 to 4 days, older children, 3 to 7 days. I mean, that's optimal, but of course, we always give the disclosure that it could be more than that as they learn as well. They figure out how to apply the products. And then as the stoma changes and normalizes, becomes sort of its regular size, that usually improves. In terms of bathing, this is something we like to review with our families because sometimes they're afraid to get into a bath. We say you can bathe with the appliance on or off. It will depend on the type of appliance that you have, and they need to test it out. We can't necessarily say that it will or will not stay on after a bath, but it is said in the literature that you can do either or. We do suggest bar soap instead of liquid soap. Again, we test the tolerance. Anything liquid soap with moisturizers can sometimes impact the ability of that appliance to stay on because the skin is just too nice and soft. And so it can come off. We do suggest to bathe over the appliance on first and then remove at the end if they're just trying to minimize perhaps the stool and like the tub for a baby. I mean, their babies are going to poop either way, so we always give that disclosure that that's okay and it's going to happen. But we also want to reassure the families that water will not get into the stoma. It's a very big misconception that their bellies are going to fill with water because they see a hole in the abdomen. So just like having them understand that it is okay for them to breathe because a lot of the times when we have issues with skin, it's because we're not bathing them regularly. That's just based on my experience, and that's the number one question I'll ask first. Who have issues with their skin, have you had a chance to wash around the stoma? Bathing is important to reset the skin. We're putting products on it continuously. We need to wash those things off to reduce that residue, sort of reset it for the next appliance so that it's not just layering and layering on top of each other. It doesn't have ability to breathe. Think of it similar to a diaper rash. You're sitting in a diaper that's moist. You've got products on there all the time. We don't necessarily leave that open to the air. Yes, it's going to be affected and likely will break down. Cleansing and skincare, we want to avoid any baby wipes and lotions near the stoma. That will likely leave a residue that will not allow it to stick very well. Less is more. If there's a product that's not enhancing the wear time, so if they don't want to put like a skin barrier spray, that's fine. They don't need to apply it. It really depends on the patient, their skin tolerance. So we give them sort of the products that we would normally use, and then they find sort of what is most useful to them. We want to avoid products with alcohol. They can often dry the skin, cause breakage. A lot of the products now are sort of no sting formulations, hypoallergenic. They sort of have these ceramides infused. So I think technology is improving a lot to reduce the chances of skin irritation, to make it more skin friendly. So I will say that about the manufacturers, that they're really trying to find the right products to stay on longer um, and reduce leakage. What are some psychosocial and school age considerations? Well, there's a lot of things to consider, but who's going to be responsible for emptying the appliance? I mean, if it's a smaller child, they're going to daycare. These are the things that we have to think about. What is the plan for changing it if it leaks? And we try and support the families to understand like how to change it, but we can't always control the factors that might affect it to leak. When we're thinking about older children, we're thinking about where will they change it. So for teenagers, is a big thing. Privacy is a big thing. Sometimes we write letters so that they're able to change it into a private bathroom versus in a public. Just gives them more time. They don't feel rushed. Allows them to sort of set everything out so that they can do it successfully. How can we support them to have less leaks at school? Well, we might need to add more uh, we may need to add more products to help kind of secure in the leaks, just so that they can get home. Things like extra barrier protection, adhesives around it to help sort of lock it in. Um, um, and then how will the child maintain privacy of their ostomy? So will they use other covers, belts? Will we have drops or things, clothing? Can that help to conceal it a little better? And how will we support the child as they adjust to their stoma? So psychosocial relationships, body image relationships, we want to think about, how will this impact sort of their day-to-day functioning? We don't want it to cause isolation. Um, we want to have these conversations and be open with perhaps their peers or their people that they look up to, such as their teachers, so that they have the support they need when they need it. And we also want to promote confidence in their new body. Takes time, definitely takes time, but we just want to have these positive conversations so that they can provide acceptance for what's happening with their body. Okay, so when we look at pediatric ostomy supplies, I don't know that they look much different. They're just smaller, I think, than some of the adult supplies. When we look at the top left here, this is our smallest device. This is called a preemie pouch. We empty it with a syringe, whereas versus we have these other ones that are two pieces that we could use a syringe as well, but can be emptied into the diaper or squeezed into the diaper. Larger, we have larger bags as well. Sometimes we use the adult bags on our smaller children, depending on the type of stoma that they have. In terms of rings, we don't have anything pediatric specific. It is exactly what we use in adults. So things like barrier rings are very similar. Stone powders, barrier sprays. Our belts may be just a little different here. This white belt here is a smaller pediatric ostomy belt. And then we think about things like just sort of supporting the ostomy in everyday life. So things like, I'm not trying to promote or anything like that, but something like a stealth belt can be used to help conceal it, help them with activity, help them to keep it on their body when they're in gym class or doing activities that they are more active with. And then things like concealing pouches, such as these bag covers, make it fun for the children, make it more inclusive so that they feel that it's not just a pouch on their body, but maybe something fun that they can put a nice print on and that makes them feel more comfortable with it. We do have these videos online, which might be helpful in learning how to change a two-piece or a one-piece. Again, concepts are very similar to adults, but if you feel, you might want to view these to see if there's any differences. But this was done by our old enterostomal therapist, or NSWAC, Teresa, who's with us for 35 years. So she now lives on YouTube on the Kids Interactive page, if that's helpful to you. So what are some financial considerations that we have to consider? The cost can vary. To be honest, like anywhere from 100 to 600 a month in some of our short gut patients, our intestinal failure patients, they could be closer to that 600 because they've got different types of stomas with higher outputs that cause frequent leakage. So we have to think about how can we best support our patients financially, because this is something that they have to live with. Not everyone has private insurance. It's great if you do. Most cover 80 to 100% of supplies. You don't typically need to write a script, but some may be a little bit more. May need a letter to supporting that they need these over the longer term, because it can get quite costly for them to reimburse them. There is an assistive devices program similar to adults for the ostomy grant, which provides, I think they've increased it because I believe it was $950 and now it's $1,300. Is the last amount that I read of annual support in 2 payments. It's usually deemed for more permanent stomas, anything greater than 6 months, which typically most of our patients qualify for. If they don't have any other coverage, then we are referring to social work to help with other methods of coverage, as such as Ontario Works or ACSD. We are usually starting these conversations in hospital, but they may require follow-up out in the community. Supplies can't be returned because, I guess, just for hygienic reasons. So we want to ensure that they're not buying too far ahead. And we're sort of reassessing as the time goes on. So the idea is to buy 1 month ahead, so that if there is leakage in that month, they can at least have enough to get by. I will let you know that our specialty food shop does have decently priced ostomy products. We don't necessarily mark up those prices. So we do encourage our families to buy from us, mostly because it just returns back to the patients. That's not a promotion of our shop, but just a reality of the situation. Parents have noted that the cost outside is quite high. So for example, I just picked some of the most common products that we prescribe to our families. So for example, this is a premium ostomy pouch. Don't worry about the brand, but these are ones that we mostly would use. But for a premium ostomy pouch, it can be $100 for 15 pouches. If you're changing that twice a week, I mean, that's a month and a half of supplies. But again, can vary because sometimes you don't buy it necessarily. It can be $100 to $140. That's quite a bit. In addition to that, we're thinking about all the other accessory products that we're using, such as the barrier ring, spray, powder, and adhesive remover. So again, we're adding that all up. That's $100 plus another $60, $80, okay, 180, 90. Okay, so that's already $200, right? For about a month to a month and a half. That's all considering that we don't have issues with the pouch and we don't have leakage. So we're just trying to be mindful of what we're suggesting to the family and how it affects sort of their income and sort of the financial impact on the family. What is our discharging plan when we come from the sick kids, or when we're in sick kids? We do an assessment within 24, 48 hours. We try and do two lessons prior to discharge. We often put a home care referral in. We apply for the ADP, and we have a surgical follow-up in 4 to 6 weeks. We do not have a clinic, but they can come see us in one of our general surgery clinics at any time when issues arise. If you feel like something is persistent that you've seen within your practice that is just not improving, we're always happy to have a conversation or bring them back to be assessed. These are the common issues that we usually tell families to come back for or to notify us about. So if you find that there's an ongoing rash, problems with leakage, there's questions about the supplies, they don't feel that they're working for them anymore, or they have sustainable prolapse or shrinking, we would love to know. So photos are always helpful in an email, or we usually put our contact email on our home care referrals. This is a little tiny box in there, so that hopefully helps for communication with us. And we also give our email to our families, so you can always ask them about that. When they should be calling the doctor or calling the nurse practitioner, or even perhaps going back to the emergency, is if they have an increase in stool, they're becoming dehydrated, they're unusually sleepy, or even irritable, they're not producing urine, they have a fever that's persistent, and there's a major change in the stoma size and color. The bleeding, less frequent bowel movements, no output. They're not crying, they're crying nonstop, or they seem to be in more pain, their abdomen is firm, Typically, these are signs of obstruction or something that needs to be investigated further. So we would likely be sending them to emergency if you do notice any of these things. I think that's it. I think we have some time for some questions and discussion. I'm just going to stop sharing my screen. Oops.
There is one question in the chat.
Yeah.
So when is a loop ostomy created versus a double barrel? Are there different purposes for these types of ostomies, and can both types be reversed?
Yes. So typically the end is the more permanent stoma, whereas a double barrel and a loop stoma can definitely be reversed. Let me just stop sharing my screen. The clinical indications, well, it will vary, to be honest. In our children, I've asked this of our surgeons. It really depends on the ability of that bowel to cope or where it is within the tract that the issue was. So, for example, I think it depends on the amount that they also resected that may decide which one they're going to use. But for a lot of our patients, like the ones with the congenital anomalies that we know, we typically do loop stomas because they are a sort of more shorter term within less than a year, whereas the double barrels may be a little bit longer, or it's just wherever they could bring it up that they had to separate the mucus fistula, the proximal and the distal end. Sometimes that's the indication for making the double barrel. Does that help answer the question for whoever asked? Yeah, so
Are we allowed
really, yeah, go ahead.
Denuded versus exorization. I'm always like stumped when charting. Like if a little bit of this is off, like as far as charting goes, like what's the difference between like denuded, exorization, open, that type of stuff?
Yeah, when we think denuded, we're thinking more of an ulceration. So there's like some depth to it, likely. There may be some discharge, or it's not looking just sort of superficial skin loss. When we're thinking excoriation, I'm thinking more of like, again, superficial, just sort of redness. It may look like skin stripping versus an actual like wound. So I guess that would depend on sort of the characteristics that you're seeing. But the treatment is very similar, right? So for a denuded wound, we're still going to fill it with stoma powder or silver powder and use the Kevlar spray. However, if it is quite significant, let's say there's like an actual significant wound size, we may have to think about using a dressing actually in place. And we have used things like hydrofiber dressing and a foam dressing, and then putting the ring on top and then the pouch.
Okay, so if it's just like maybe like a few tiny layers off the top, not like depth or anything, I should say exorization versus yes. Okay. And then that is, what are the properties of stoma powder? Like what
is it? What does it do? I like to think of it as a zinc oxide in a bottle, so in a powder form. Yeah. So when we can't use creams and lotions, you can, but it's very difficult to get the skin dry enough. And then we use the powder to help dry the area to seal it. So think of it similar to a zinc oxide formulation. When we're using the silver powder, though, which is obviously it's over the counter, anyone can buy it. You don't need a prescription. We do have to think about sort of long-term usage. So we typically use it only for 7 days, and that should have helped the issue that we're trying to resolve.
There's another question in the chat. How long do you and how often would you apply a cool cloth? And then a secondary question to that, the concentration of granulated sugar that you spoke about.
Yeah, so families always ask this and are surprised when we say put the sugar on. It's just regular table sugar, white table sugar. And there really isn't an amount, but we do want to saturate the stoma with it. So whether they introduce it into the bag, empty the bag, and then just throw a bunch of sugar on top of the stoma, you want to coat the stoma. It does get very messy, it gets very sticky, obviously may require a bag change. So we do give that disclosure. But usually immediately you'll see that it reduces once the sugar touches the stoma. So there isn't really an amount, I would say, but probably about a cup or more if it's a larger stoma. For the cool cloth, we do it in increments. So we usually just say for a couple of minutes, and we don't necessarily apply it directly onto the stoma. So over the clothes, onto the stoma, and do it for a few minutes at a time. I would say we would repeat that, maybe for a few hours and to see if that helps. But typically, again, you'll see a reaction within the first few minutes. If it doesn't reduce, but it's not causing them any issues, then they don't have to worry. I wouldn't worry about it necessarily. Again, it's just more for comfort, or if they're trying to get a pouch on, then that's typically when they would want to shrink it down so that they can at least get the pouch over it. Does that help? Yeah, okay, great. Is there anything, that you've seen in your own practice, or things that you've had patients that were perhaps referred from us, that you had questions about? We're really just trying to improve our partnership and just understanding how we can best support our patients and families once they leave us. We sometimes transfer our patients to other peripheral hospitals, so we're just wanting to know whether you feel comfortable in accessing your own NSWAC in your area to help with these issues, or if you feel like we need more training, or to have these conversations on what we're using and what you're using and how we can tailor that. I'm really open to hearing about that.
I guess I would just comment that I have accessed you guys before for other issues, and it's been so helpful. So us community nurses are so appreciative of this program because it is really, really helpful and supportive. So thank you.
That's great. Yeah, we're really looking to build our connection with Connected Care, building more resources available to yourselves, the families, patients, for ostomy resources. So look out for new resources coming on ostomy A to Z's, videos, and just online resources. We're hoping that's helpful. That's great. I feel like if there's no more questions, always happy to drop it in the chat. If you feel like you want to connect further, feel free to reach out. I didn't necessarily leave my email there, but I can. We have a general email. I'll put it in here just for general questions. And obviously, if it's our patient, we can help. But if you have general pediatric specific questions, we can sort of give you some general guidelines. But this is our email address.